Today in this class, we will discuss about the caecum and appendix. Caecum is about 6 cm long and 7.5 cm broad, blind sac forming the commencement of the large intestine. It is situated in the right iliac fossa above the lateral half of the inguinal ligament. Caecum communicates superiorly with the ascending colon. Medially, at the level of the cecocolic junction, it communicates with the ileum, and posterior-medially, it communicates with the appendix. Caecum is related anteriorly with the coils of intestine and anterior abdominal wall. Posteriorly, caecum is related with the right psoas major and iliacus muscles, genitofemoral, femoral and lateral cutaneous nerve of thigh, and to the testicular or ovarian vessels and appendix in the retrocecal recess. Here in this dissection, you can see the caecum, which is a blind sac, and it communicates superiorly with the ascending colon. Here you can see the ascending colon, this is the transverse colon, and here what you can see is the descending colon. Medially here you can see it communicates with the ileum, and posterior medially here you can see it communicates with the appendix. Vessels and nerves. The appendix and the caecum is supplied by cecal branches of the iliocecal artery. The veins from the caecum drain into the superior mesenteric vein. Caecum is supplied by T11 to L1 sympathetic nerves. Development. The caecum and appendix, they develop from the cecal bud arising from the post-arterial segment of the midgut loop. The proximal part of the bud dilates to form caecum. The distal part of the bud remains narrow to form the appendix. Thus, appendix arises from the apex of the caecum. Due to the rapid growth of the lateral wall of the caecum, the attachment of the appendix shifts medially. Iliocecal wall. The lower end of the ileum opens on the posterior medial aspect of the iliocecal junction. The opening is guarded by iliocecal valve. The iliocecal valve has two lips and two frenula. The upper lip is horizontal. It lies at the iliocecal junction. The lower lip is longer and concave. It lies at the iliocecal junction. The ends of the lip, they fuse to form the left and right frenula. The left end is rounded and the right end is narrow and pointed. The control of the iliocecal valve. The valve is actively closed by sympathetic nerves which cause tonic contraction of iliocecal sphincter. Mechanical closure of the iliocecal valve is done by distension of the caecum. The functions of the iliocecal valve is to prevent the reflex from the caecum to ileum. It regulates passage of the ileal contents into caecum and prevents them passing too quickly. Here in this dissection you can see that here the anterior wall of caecum has been cut and removed to expose the lumen of the cecum and to show the ileocecal valve which has got two lips, a superior and an inferior lip. Here you can see the ileocecal artery which gives the cecal branch which supplies to the cecum, and it gives a appendicular branch here, this appendicular artery which enters the this mesoappendix. Yeah, this is the mesoappendix, that is the peritoneal fold which suspends the appendix, and this is the appendix you can see. So this, you can see the ileal artery, the appendicular artery entering into the mesoappendix to supply the appendix. Clinical anatomy. The cecum is commonly involved in number one, amoebiasis, causing amoebic dysentery. Often, the amoebiasis presents as a tenderness in the right iliac fossa. Then, uh, intestinal tuberculosis, also known as ileocecal tuberculosis, and carcinoma of the ileocecal junction. This presents as a lump in the right iliac fossa, often causing subacute intestinal obstruction. Then inflammation of the cecum is known as cecitis or typhlitis. Often it presents with the tenderness in the right iliac fossa. Here in this diagram of the ileocecal junction, you can see the anterior wall of the cecum, and the terminal part of the ileum has been cut and removed to expose the lumen of this cecum and ascending colon, and here you can see the ileum. This is the ileocecal junction. Here the lips, superior and inferior lips of the ileocecal valve, and here you can see the superior ileocecal fold and the inferior ileocecal fold. This region has been enlarged here to show the formation of the ileocecal junction, and here you can see the circular muscles that are inside and transverse muscles they are outside, they get thickened to form the ileocecal valve. Here you can see the ileocecal orifice. The vermiform appendix is a worm-like diverticulum arising from the posteromedial wall of the cecum. It is about 2 cm below ileocecal valve. The length of the appendix varies from 2 to 20 cm with an average of 9 cm. It is longer in children than in adults. The diameter is about 5 millimeters and the lumen is quite narrow, and it may be obliterated after mid-adult life. The position of the appendix is it it lies in the right iliac fossa. The base of the appendix is fixed. The position of the tip varies from person to person. Position of the tip is often compared with the hour hand of the clock, and as such the paracolic position or the 11 o'clock position, here the appendix passes upwards and to the right. The retrocolic or the 12 o'clock position, here the appendix lies behind the cecum, and this is the most common position. Retrocolic appendix is the most common position, common in about 60%. The splenic. when the appendix may pass upwards and to the left towards the spleen. This is the 2 o'clock position. Appendix may lie in front of the ileum, that is the pre-ileal, or it may lie behind the ileum, that is the post-ileal. Pre-ileal appendix is most dangerous. Then the promontoric, that is 3 o'clock position. The appendix may pass horizontally to the left. The pelvic position, that is the 4 o'clock position, the appendix may descend into the pelvis. This is the second most common. The pelvic position is the second most common position and it is present in about 30% people. The subcecal are the mid-inguinal, that is also known as 6 o'clock position. Here the appendix pass below the cecum, it points towards the inguinal ligament. Here in this diagram, the various positions of the appendix has been shown. Here you can see the ascending colon, this is the cecum, this is the tinea coli. Here you can see this is the paracolic position at the 11 o'clock position. This is the retrocolic position. This is the subcecal position. Here you can see the pelvic position. This is the ileum. The appendix may pass pre-ileal or it may pass post-ileal, and this is the promontoric position. In this section, the appendix and the cecum has been observed from the posterior aspect. Here you can see the terminal part of the ileum. This is the terminal part of the cecum, and here you can see the root of the appendix. Appendix is directed upwards behind the cecum. Here you can see the tip of the appendix, and this is the mesoappendix, that is the fold of peritoneum suspending the appendix. And here what you can see is the posterior cecal vessels, the branches of the ileocecal vessels, and they are supplying to the cecum. The appendicular orifice is situated on the posterior medial aspect of the cecum, 2 cm below the ileocecal orifice. Occasionally, it is guarded by an indistinct semilunar fold of mucous membrane known as valve of Gerlach. The orifice is marked on the surface by a point situated 2 cm below the junction of the transtubercular and right lateral planes. McBurney's point is the site of maximum tenderness in appendicitis. The point lies on the junction of the lateral 1/3 and medial 2/3 of a line joining the right anterior spine to the umbilicus. Here in this diagram, you can see this is the right lateral plane, this is the transtubercular plane, and you can see the position of the base of the appendix lies 2 cm below the point where the right lateral plane crosses the transtubercular plane. The McBurney's point also you can see here is the anterior spine, is the umbilicus at the junction of the lateral 1/3 and medial 2/3. You see the McBurney's point where the tenderness of the appendicitis is seen. The lumen of the appendix is quite small and may be partially or completely obliterated after mid-adult life. The peritoneal relations. The, the appendix is suspended by a small triangular fold of peritoneum known as mesoappendix or the appendicular mesentery. The fold of peritoneum passes upwards behind the ileum and is attached to the left layer of mesentery. The blood supply of the appendix is derived from appendicular artery, which is an end artery. It is a branch of lower division of ileocholic artery. It runs behind the terminal part of the ileum and enters the mesoappendix at a short distance from its base. It gives recurrent branch which anastomoses with the branch of the posterior cecal artery. The main artery runs towards the tip of the appendix. The terminal part of the artery lies on the wall of the appendix. The veins are drained by the appendicular, ileocholic, and superior mesenteric veins to the portal vein. Here, in this dissection, you can see the appendicular artery. This is the ileocecal artery, and here you can see the cecal artery, which is a branch of ileocecal artery, and the appendicular artery arises from the posterior branch of the ileocecal artery. It enters into the mesentery of the appendix or the mesoappendix. So here you can see, and this artery, this is the appendix. You can see the mesoappendix, and this artery, it runs in the mesoappendix and reaches to the tip of the appendix. Here, this is a diagram showing the blood supply of the cecum and appendix. You can see the inferior division of the ileocecal artery, which gives anterior and posterior cecal branches. The posterior cecal branch gives the appendicular artery, which near the base gives a recurrent branch, which anastomoses with the posterior cecal artery, and the main branch you can see it runs in the mesoappendix to reach the apex of the appendix. Nerve supply. The sympathetic nerves are derived from T9 and T10 segments through the celiac plexus. The parasympathetic nerves are coming from the vagus. The referred pain of the appendix is felt at the umbilicus, similar to that of small intestine and testis. The lymphatic drainage. The mostly lymph drains into the ileocholic lymph nodes. A few lymphatics indirectly pass through the appendicular nodes present in the mesoappendix. Histology. The lumen of the appendix is very narrow. There are mucosa, so no villi. Epithelium of the mucosa invaginates to form the crypt of Liverpool. The musculus mucosa is ill-defined. The submucosa reveals many lymphoid masses. That is why it is called abdominal tonsil. The muscularis externa comprises two layers. The outermost covering is the serous layer. Here in this H&E stain section, you can see the appendix. The lumen of the appendix is very narrow. Here you can see the mucosa. This is the lining epithelium. Shows that it is folded to form the crypt of Liverpool. The this is the lamina propria, which shows the lymphoid collections. This is the submucosa, and this is the muscularis mucosa, and here you find the serosa. The glands are often spaced apart. The diffuse lymphatic tissue with germinal centers in the lamina propria and adjacent submucosa, and that's why it is called the tonsil of the abdomen. The outermost layer is the serosa. Clinical anatomy. The pain of appendicitis is first felt in umbilical region. It is referred pain because both appendix and umbilicus are supplied by T10 segment, appendix by the sympathetic fibers and umbilicus by the somatic fibers. With increasing inflammation, pain is felt in the right iliac fossa because of involvement of parietal peritoneum. The appendicitis is common because of the presence of lymphatic follicles in submucosa. The appendicular artery is an end artery, and as the lumen is small, it gets obliterated by fibrillary. Gaps in the muscularis externa cause fast spread of the infection. The McBurney's point is the site of maximum tenderness of appendicitis. The McBurney's point lies at the junction of lateral 1/3 and medial 2/3 of a line joining right anterior superior iliac spine to the umbilicus. It roughly corresponds in position to the base of the appendix. When the appendix is retrocecal, the extension of the hip joint may cause pain because appendix is disturbed by stretching of the psoas major muscle. In pelvic appendicitis, the pain may be felt when the thigh is flexed and medially rotated because artery internus muscle is stretched. The appendicular dyspepsia. This is a chronic appendicitis produces dyspepsia resembling the disease of the stomach, duodenum or gallbladder. It is due to the passage of the infected lymph to the subpyloric nodes which cause irritation of the pylorus. There is history of the earlier acute appendicitis. Here in this diagram, you can see the McBurney's point. This is the anterior superior spine, this is the umbilicus, and at the junction of the medial 2/3 and lateral 1/3, you find the McBurney's point. This is the ultrasonography of the appendix. You can see this appendix here, and this is the caecum you can see, and this is the appendix you can see. So you can visualize the appendix in ultrasonography. You can also visualize the appendix in the CT scan, and here you can notice the lumen of the appendix does not show the contrast media. Contrast media does not enter into the lumen of the appendix. Here you can see the swollen appendix because of the appendicitis. So that is all about the caecum and appendix.